was built to last. When the webs are weaving, I could change the past. With all of
Hello everyone, welcome back to the channel. We're gonna start off today by questions from rheumatology. We're gonna use the educational objectives from UWorld, NPSAP, and ACP for internal medicine to create our own questions. And these questions are gonna have no fluff. They're gonna be directly to the point, and they're gonna test your knowledge of the most importantly tested educational objectives on the internal medicine boards. So I have created this way for the GPT4o I've given it instructions on how to create questions and what to do with the educational objectives so that we have the most relevant information. If you're excited for that, drop a thumbs up, a like, subscribe, and you will be able to access the notes from my sessions whenever we talk about. It's going to be all available on the Patreon channel if you want to check that out. So let's go ahead and get started. This is a 62-year-old man. He presents to the clinic with 4-month history of joint pain involving his knees, wrists, and ankles. He has a 30-pack-year smoking history, and on exam he has digital clubbing and mild periarticular swelling in multiple joints. The labs show normal inflammatory markers and a negative rheumatoid factor and anti-CCP antibodies. A chest X-ray reveals a 4.5 centimeter mass in the right upper lung. What is the most likely cause of this patient's symptoms? So go ahead and pause the video right here, pick your answer, and then we're going to go through the questions together. All right. So the options were rheumatoid, hypertrophic osteoarthropathy, seronegative spondyloarthritis, perineoplastic dermatomyositis, and erosive osteoarthritis. So the correct answer, of course, is HOA. And this question tests this very strong association that we're going to talk about. So HOA, or hypertrophic osteoarthropathy, is a syndrome of digital clubbing and periosteitis, which basically means inflammation of long bones. It is associated with underlying intrathoracic disease. Remember that. Most commonly non-small cell lung cancer, or NSCLC. The mechanism is that the tumor produces factors like vascular endothelial growth factor, or VEGF, which promote new bone formation, causing periosteitis and digital clubbing. So the findings of clubbing, joint pain, periosteal inflammation affecting especially the distal extremities are very, very suggestive of HOA. And so the first question, the first part was the rheumatoid arthritis. That's incorrect. RA presents with symmetric joint inflammation, does not cause clubbing or periosteal new bone formation. Also, the markers were negative. The seronegative spondyloarthritis, that's negative. That's incorrect because those are usually associated with ankylosing spondylitis or psoriatic arthritis affecting the axial skeleton and causing entheses, not distal joints like HOA. And also there's no clubbing in that case. The paraneoplastic dermatomyositis is incorrect because remember, dermatomyositis causes proximal muscle weakness, and the characteristic findings on the skin are the Gottron papules and the heliotrope rash, which were definitely absent in this case. And then the erosive osteoarthritis, that would be just the OA. It affects the weight-bearing joints, the interphalangeal joints, but does not cause clubbing or periosteitis. So then going through clinical decision-making algorithm. So again, joint pain, clubbing, and if someone who has a history of lung, the smoking, you consider HOA, and you have to rule out underlying lung cancer. And the preliminary imaging you can get is a chest X-ray to identify it. And even if the chest X-ray is negative, I would say to suggest to check for a CT of the chest, because sometimes the chest X-ray may not be as accurate in diagnosing the underlying cancer. Bone imaging, you can take a look at the bones and to find the periosteal new bone formation. So again, clubbing, joint pain, think HOA, smoker, new arthritis, and periosteal thickening, suspect lung cancer. And always check the chest. And then if lung cancer is detected, once you treat the lung cancer, the HOA should resolve. And you can use NSAIDs for just symptomatic relief. And the key clinical pair, again, you don't need to treat HOA per se. You treat the underlying cause. Okay, and just remember that the high yield takeaway that suspect the lung cancer in a patient with clubbing and arthritis-like symptoms. All right. Especially with someone who has history of smoking. All right, so let's go ahead and move on to the next question. So this is an 80-year-old woman. She presents with progressive right shoulder pain and swelling over the past few months. She denies trauma, fever, or systemic symptoms. Examination reveals limited range of motion and a large tense effusion in the right shoulder. Imaging shows periarticular calcifications and destructive arthritis of the glenohumeral joint. The joint aspiration reveals hemorrhagic effusion, but no crystals are seen under routine light microscopy. Okay, so no crystals, but there is hemorrhagic effusion. So what is the most likely diagnosis in this case? So the first option is septic arthritis, then is the CPDD, and then it's the basic calcium phosphate deposition disease or Milwaukee shoulder, then rheumatoid, and the last option is osteoarthritis. Go ahead and pause the video right here, pick your answer, and then we're going to go through each one together. All right, so the answer is actually BCPD, or the basic calcium phosphate deposition or Milwaukee shoulder. So the pathophysiology is that, it's a type of basic calcium phosphate deposition disease that involves aggressive joint destruction, especially of the glenohumeral joint and rotator cuff. It causes hydroxyapatite crystals to accumulate in the joint, and they lead to inflammation and progressive erosion. The hallmark of a Milwaukee shoulder is hemorrhagic effusion. But remember that BCP crystals are not visible under conventional microscopy. They actually require a special staining. So you will not be able to find that. And if the microscopy is negative for crystal, doesn't mean this cannot be there. Septic arthritis is incorrect, because remember, this would be more acute onset. You would have purulent joint fluid, you have high WBC, maybe greater than 50,000. This patient's symptoms are more chronically presenting, and there's no other findings like purulence or anything like that that would suggest infection. The pseudogout or calcium pyrophosphate deposition, this would be incorrect. It does affect knees, wrists, and other large joints more commonly than the shoulder, as we know. And also, you may find the rhomboid-shaped crystals under polarized light, and which are absent here. Another point that I would share is that the way that CPD presents is more than just 4 months and then hemorrhage. This is, I would say, still it says past few months or few months. I would say if pseudogout was gonna present with such a destruction or destructive disease, it would have to be there for years to get there, at least based on my knowledge and understanding of medicine of cases I've seen. Rheumatoid arthritis would be incorrect. RA can cause symmetric inflammatory arthritis and is associated with systemic symptoms. It does not cause hemorrhagic joint or periarticular calcification. And of course, osteoarthritis would be, again, a gradual loss. It doesn't cause really a large hemorrhagic effusion or rapid, I would say, joint destruction. So when you see an elderly patient with shoulder arthritis with hemorrhagic effusion that kind of presented rapidly, suspect Milwaukee shoulder. And Milwaukee shoulder is a basic calcium phosphate deposition. It's different from pseudogout, which is the calcium pyrophosphate deposition disease. The X-ray findings are the periarticular calcifications and a significantly destructive arthritis. And when you aspirate the joint, you find a lot of hemorrhage. There won't be crystals on the routine microscopy. It will actually need staining for the hydroxyapatite. And so this kind of tells you about the findings, the pattern recognition, okay, and the latest guideline check. So X-ray or MRI to confirm the periarticular calcification joint destruction. You can give NSAIDs and intra-articular steroids for symptomatic relief, and of course physical therapy to maintain function. If they have very severe case, then they may require shoulder arthroplasty. And the clinical peril here was, unlike gout or pseudogout, BCP crystals cannot be seen on routine microscopy, making clinical diagnosis very crucial. And I'll tell you, even sometimes for gout and pseudogout, you may not find crystals on a routine microscopy. So you really need to, when trying to diagnose these conditions, really focus on the clinical diagnosis, both in practice and on boards. Always suspect Milwaukee shoulder in elderly patient with chronic shoulder pain is rapidly progressive hemorrhagic effusion and periarticular calcification. All right, if you enjoyed this question and if you've been with me through this time to the video, we have one more question. Let's go ahead and give me a like and a subscribe, and then we're going to continue on with the next question. All right, board styles. Okay, so this is a 75-year-old woman who presents for osteoporosis screening. She has a history of osteoarthritis and chronic low back pain. A DEXA scan reveals a T-score of a negative 2.6 at the hip and a negative 1 at the lumbar spine. X-ray imaging shows osteophyte formation and syndesmophytes at the lumbar spine. What is the most likely explanation for the discordance in bone density results? So go ahead and pause the video right here, pick your answer, and then we're going to go through the options together. All right. So the answer here is that the localized increase in bone density. So a lot of times patients with chronic degenerative joint disease and back issues develop osteophytes, and these osteophytes can basically throw off the results of a DEXA. So we'll see here, bone density measurements can overestimate true bone strength in certain conditions, leading to discordant DEXA results. The osteophytes and the syndesmophytes increase local X-ray absorption, vastly elevating the lumbar spine T-score. True osteoporosis is reflected in the hip measurement, which is more accurate than the lumbar spine in this case. And also remember, those are areas that are hips are more would be more accurate areas to check. Vascular calcifications can also interfere, but they typically affect the aortic regions, not just the lumbar spine. Okay. So the first option was measurement error. That would be incorrect. Consistently high lumbar spine density suggests a real phenomenon, not a technical error. Osteomalacia. This causes actually low bone density across all of the sites and not just a selective part of lumbar spine. Overstimulation due to vascular calcification would be incorrect. Those are aortic ones and can vastly elevate the lumbar T-scores. But osteophytes are a more likely cause in this patient with OA. And secondary osteoporosis due to hyperparathyroidism, this also would be incorrect. Remember, primary hyperparathyroidism causes greater hip bone loss than spine, but it would not selectively increase the lumbar density. It wouldn't be just one area again. So when you go through the kind of the clinical decision making, discordant DEXA results, lumbar spine more than hip, look for the osteophytes, maybe look for compression fractures, look for, if it was in the T-spine, look for vascular calcifications, and that could be throwing your test off. Determine the true osteoporosis risk. The lowest T-score, which is typically in the hip or the distal radius, should guide your treatment. If a hip T-score is less than negative 2.5, you have to start the anti-resorptive therapy like bisphosphonates. And if the discordance is unclear, we can consider to check alternative sites such as the distal radius. So always remember, if you have an elderly with lumbar spine T-score that is high but the hip that is low, think about the osteophytes. And again, OA plus syndesmophytes on imaging suspect overestimated lumbar bone density. The latest guidelines, osteoporosis treatment is based on the lowest measured bone density. Prioritize hip over the spine. And bisphosphonates are first line in postmenopausal osteoporosis. If lumbar spine T-score is artificially high, consider wrist DEXA for confirmation. And the clinical play, always use the lowest T-score. Okay, so and it creates a good interesting mnemonic here: osteophytes overestimate osteoporosis. So basically, as you can see, I've asked it to go through all of these steps here. All of these are an instruction to break down this question, and it's trying to basically adhere to my instructions and give these points. So thank you so much. If you stayed all the way till the end of this video, drop a like, put me a comment, make any recommendations, any videos you want to see, any more questions from a specific section you would like to see. We're going to continue to do this. We'll do it till we have every educational objective tested, not in one way, in multiple ways, and we'll create connections between the educational objectives once we cover every system. Okay, and every question can present, every objective can present in many ways, and with AI we're going to be able to create our own questions so many ways that we cannot miss basically on the board exam. Okay, so thank you for being here. I'll see you on the next one.